Thanks, John. Yep, so I'm going to be at the ECI part-time for the next 6 months, and when I'm not there, I'm at Vinnie's. And I thought I'd take the opportunity to talk about some research that we've had accepted for publication this year in Emergency Medicine Australasia about delabeling penicillin allergy from within the ED. So what's the issue? Penicillin allergy is extremely common. It's the most reported allergy to medication that we get from our patients, and pretty consistently about 10% of patients do report the allergy. In order to avoid giving our patients an anaphylactic reaction, we have to choose a second-line antibiotic when they need antibiosis. These are more expensive, put our patients at increased risk of side effects, and also create a selection pressure for multi-resistant organisms. And the history of penicillin allergy in itself is quite unreliable. There's a large body of research showing that when someone reports an allergy, the chances that they actually do have a demonstrable allergy are only sort of between 10 and 20%. The significant majority, it's a false allergy. They were told, I was told by my parents I should avoid penicillin, I felt nauseous, I had a rash, which can often be due to the coexisting medical condition at the time. So the majority of testing for penicillin allergy is started off with skin testing. This is demonstrating a skin prick testing and intradermal testing here. And it's looking for that IgE-mediated hypersensitivity, and that's the way that anaphylaxis manifestates. So the idea is if a patient doesn't have any reaction to the skin testing, they're very unlikely to have a more severe anaphylactic reaction. Each little dot here is either a skin prick, where a drop of reagent is put on the skin and there's a small scratch made with a lancet, or could be an intradermal test, which is a very small bleb is injected into the dermis. And then the patient's observed to see if there's a wheal and flare reaction. So it looks like here and here we're getting that reaction. So the issue is that the skin tests have been around for about 60 years. They're safe. Reported systemic reactions during the skin test is about 1 in 1,000 to 1 in 400. And if they're negative, clinicians can go on and proceed with an oral drug challenge. So they can actually provide the patients with that suspected reagent, or in this case, penicillin. And a review of the literature, about 6,000 patients reporting a penicillin allergy, but with negative skin tests, none of those went on to have an anaphylactic reaction. So they're safe in the procedure and also allow safe challenge of the drug. The issue is these are in the domain of allergy specialists, usually carried out in allergy clinics. They require referrals from a general practitioner. They often have long waiting lists, and it requires significant motivation for a patient to get the referral and attend clinic and get delabeled from the allergy. So, what can we do in the emergency department? This paper by Raja et al. In 2009 was carried out in an American ED, where they skin tested 150 patients reporting a penicillin allergy. They weren't able to complete with a drug provocation test, but they did. So they weren't able to completely delabel them, but they certainly tested these patients and found that 91% had no reaction to skin prick testing. So our study, carried out in St Vincent's from 2011 to 2016. Inclusion criteria was adult under the age of 86 and reporting a penicillin allergy. We had a few exclusion criteria if they were critically unwell at the time of presentation, pregnancy, and if they reported a clear history of severe anaphylaxis. Now, there are a few medications that we excluded from the study that were thought to interfere with either the results of the studied test or the severity of an allergic reaction. And what we were focused on was it safe, and what was the perceived allergy status at the end of the test with our participants. So this is just a little schematic of our testing. If you remember back to the picture of the forearms earlier, each of these is a testing little unit. So up here we have the skin prick testing. That's the first part of the test. So we have controls, the histamine, that's always going to get in the majority of cases will get a response, and the saline, which shouldn't get a response. And then these two are the breakdown products, the major and minor determinant are the breakdown products of penicillin to which people mostly react. But we also included amoxicillin as well. It has a side chain that has slightly different reaction profile. So we would put a little drop of solution on the skin, scratch with a little lancet, and observe them for 15 minutes. And if there was a wheal and flare, so a skin reaction of over 3 millimeters, that was positive. We stop there. Looks like you're allergic to penicillin. If that was negative, we go on with the intradermal testing. So that small little solution under the epidermis, starting with a 1 in 100 dilution, then a 1 in 10, and then a neat dilution. Each one followed by observation to allow the skin to react or not. If patients were negative with their skin testing, we continued with what's called drug provocation testing. This is the oral challenge. We had 2 different strengths of amoxicillin syrup, and we could give them in the emergency department their first dose, a tiny dose of 2.5 milligrams, and again watch them for half an hour, make sure they didn't have any reaction. If that was all fine, they were discharged home with a daily dose of amoxil, increasing each day to 250 milligrams, a low normal dose on the last day. So in total, the time it took to perform the testing was about 30 minutes, but patients had to stay for at least an hour and a half of observation after each of those little points there to make sure there were no effects. Okay, so we had 103 participants take part in begin testing. 2 of them had positive skin prick tests at the outset. 14 patients subsequently had positive intradermal testing, and obviously we didn't continue with any testing there. We said, look, it looks like you do have a true allergy, best to avoid penicillin. So the significant majority obviously had negative skin tests. We were then able to continue with the drug provocation testing, although we had one patient withdrew from the trial before skin testing. She had a headache that was not classified as a reaction, and she withdrew consent for the study, and 2 patients were lost to follow-up. So of the 84 patients that continued and completed the oral challenge, 1 reported an urticarial rash and tingling lips about 2 days after starting the drug challenge, and we said, that sounds like an allergic response, you should stop and not continue with the trial. And then 2 patients reported rashes at the end, about 8 to 9 days after being on the drug. We said, look, that doesn't, we are not assessing that as an IgE-mediated hypersensitivity, so it's very unlikely you'd have anaphylaxis, but you are showing some kind of response that we think might be due to the penicillin, so best avoid that. So all those people, we did not delabel from their allergy status. But of the 100 patients that we had that completed the study, we have the data for, we managed to delabel 81. So just reiterating the first part, that 81% reporting the allergy, safely tolerated 250 milligrams of amoxicillin. The study was safe. There was no serious adverse events other than those mentioned earlier. There was one case of someone reporting itch on the last day, someone reporting some nausea, and someone reporting diarrhea, but no serious adverse events. I also think our study highlighted that the drug provocation test, the oral challenge, was of low yield, but still significant, because this patient here who reported the IgE-mediated response, the urticaria, the tingling lips, if done just by skin tests, she may have been falsely delabeled from the allergy, and if challenged later, could have had a more severe reaction. Now you might have noticed that the study went on for quite a long period of time to get those number of data. There were some challenges in terms of enrollment and testing due to sort of rotations of the clinician and some of the systems we had in place, like a lack of searchable allergy data. We don't use EMR at our hospital. And obviously, the number of patients entered into the study compared to those presenting or who could potentially have been eligible during that time was quite small, putting them perhaps a risk of selection bias. But obviously, our results do fit with those that have been studied previously. Now, it's important to note that our study was designed just to identify this IgE-mediated hypersensitivity. And there were other reactions described that may result in intolerance. For example, if that patient did have, gastrointestinal symptoms, she might not be classically IgE hypersensitive, but they might be intolerant to penicillin in other ways. And obviously we had strict selection and exclusion criteria for our study, and we excluded severe anaphylaxis. In those patients, they might have displayed higher results to our testing and perhaps more adverse events. So, what does this mean in terms of useful clinical practice? In order to make sure, to reduce our risk of adverse events and errors, we had an extremely thorough testing procedure. We didn't want to either challenge someone with too much of an antigen and make them unwell in the emergency department, and also we didn't want to falsely delabel someone. So we had quite an extensive testing procedure, 2 hours in the ED and 9 days at home. And can we abbreviate this? If we can shorten the testing time, it's likely we can reduce the labour costs, which coincidentally we put at about $110 each per patient. And we should be able to improve the compliance as well, because otherwise also you're asking patients to go through, 11, 15 needles and then take a medication that they think they're allergic to at home for 9 days. It's quite a lot of ask. So if we can reduce that burden, we should be able to improve the compliance with the testing. And hopefully, with short enough testing, we might be able to guide antibiotics during an index presentation if they are required. Now, the possibilities I've thought about how we could achieve that is either abbreviating the skin testing itself, perhaps removing the 1 in 100 dilutions or the 1 in 10 dilutions if they had a negative response to the skin prick testing. Those didn't seem to be important steps from our data. And I guess the goal is also really reducing that drug provocation test. Now, reducing the length of time, the duration for that. Previous studies have looked at quantifying the likelihood of someone's penicillin allergy based on their history, and that has identifiable response in their likelihood of allergy. So if they are classified as low likelihood, they were less likely to have the allergy. And interestingly, a recent study in the American Journal of Pediatrics assessed children with penicillin allergy and quite accurately defined their risk on history, also including communication with their primary care pediatrician. And they actually tested all those children with skin prick and drug challenge, and none of them had any allergy at all. So is there a utility in improving our sort of pre-test probability and giving those patients a really short challenge, perhaps just even a one-off normal oral dose of amoxicillin, with or without negative skin testing? So those are some of the ideas for how we can put this into practice. So just in summary, from just going over our results, our study was safe, showed a significant majority of people reporting penicillin allergy can safely tolerate it, and the thorough testing is quite time-consuming and might need some tweaking before we can introduce this into clinical practice. Happy to take any questions.
Any questions from the floor? Perhaps I'll kick off. Joe, who prepared your solutions? Did you guys do that yourself, or did you get the pharmacy to?
So the reagents are sold for testing, specifically for skin testing, and they are dry reagents that we made up ourselves. That was part of the difficulty of the limitation of the length of the study. When they were first made, they had a shelf life of 24 hours, we were told. During the course of the study, they said, oh, okay, now the shelf life is a week. So obviously when the shelf life was just 24 hours, it's very difficult to get the patient numbers through to justify the cost of the reagent. When they extended them to a week, we were able to test more patients, and we needed to get people in batches. With the amoxil, that was made up by pharmacy. So 2 different bottles with powder that we would reconstitute when the patient was being tested.
Any other questions? I'd be.
Thanks for that. Thanks. Is your thought, and sort of going on from here, that the emergency department is the appropriate place to challenge these patients because other places are full, or because it's something that we should be doing because it helps our patient flow, and who kind of should have ownership of this?
Yeah, that's a great question. I mean, it does not obviously affect or improve, the ED results doing this. Is it an answer to a systems problem that again is just, the ED can help out here because we can do other things. But in a serious note, it's a place where resuscitation facilities are available to treat anaphylaxis, and those must be available in an allergy centre as well. So it's not got obvious benefits that are specific to ED. It's a whole of ED, whole of patient sort of population improvement. There is the idea that ED short stay units could do this. So that's not going to interfere with performance times. But yeah, there's no reason why ICU couldn't do this, or other hospital systems. But it's just part of the criteria is having a place where you can resuscitate people if you've given them an anaphylaxis.
Do you think you can apply this finding to IV use or just oral?
In terms of giving people the challenge?
Yeah. No, for the further use of the penicillin. Sorry, thanks. Do you think this finding can be applied for the IV use later or not?
Well, so if patients came out of our study and were delabeled, we said you are free to use penicillin. So we would be happy.
Or oral?
Yeah, either. Yeah, we'd be happy to give them an
But
IV.
the pharmacodynamic or pharmacokinetic of the oral use is different from the IV. They may I don't know, maybe a small percentage of them just show some reaction to IV form.
Well, our thought is they've had 9 days of systemic use of penicillin, and it's amoxicillin, which would contain the amoxyl side group and the 2 breakdown products of penicillin. So from our understanding, that would mean that they do not have an anaphylactic reaction to penicillin or those subgroups, and would be safe for IV use. IV administration as a challenge is not recommended.
No,
Yeah.
the challenge is treatment.
As a treatment, yeah, we'd be happy to give these people IV penicillin after a successful negative challenge.
Joe's more recently done exams than me, so I can't even remember, but I wouldn't think that the kinetics would affect an IgE reaction. They're systemically absorbed, then they're there.
You know that the bioavailability of the oral form is different from the IV.
Yeah, but the bioavailability is a quantity, not a quality process, unless we're suggesting that the active breakdown products and the ingredients are getting extracted.
It's not just as simple as that, because it depends if they have been exposed previously to penicillin or not.
I guess in your literature review, did you see that you had that the serum things that you're looking to test, they're measured in the serum from the amoxyl? Is that the case, or is this a in vitro?
The breakdown products?
Yeah.
I'm afraid I can't recall where they're tested from. There was that they are the PPL and the MDM are the breakdown products, and they form haptans and are identified as such.
I guess we'll just have to review the RCAs in the next few years and see if they've got Joe turns up on them. Thanks very much, Joel. I think it's beautiful, simple, but very important work, and I think that we're all frustrated with all the penicillin allergies, and we've got to use other drugs, more expensive drugs, and delayed treatment. So I think there's a cost, there's an opportunity cost, and also perhaps a real cost in terms of time and money. So I think it's great. Thanks very much.
Pleasure.